afternoon to one and all present here. I'm Dr. K. Sofia from India. I'm going to talk on a report of 2 cases of incarcerated vaginal pessary. The first case report is she was a 68-year-old female, para 8, live 7, abortion 1, with previous normal vaginal deliveries without any complications. Her last childbirth was 25 years back. She attained menopause 15 years back, and she presented to our OPD with complaints of suprapubic pain and difficulty in menstruation. Patient was a known case of pelvic organ prolapse for which a ring pessary was inserted 2 years back by a general practitioner, and she was not given any instructions regarding her follow-up visits. And there was no history of bleeding PV, discharge PV, or any pain. And she was known diabetic for 5 years on regular oral hypoglycemic agents. Her menstrual history was normal, and there was no other significant history. Her general condition was fair, she was not anemic, her vitals were stable, systems were within normal limits, her abdomen was soft. Speculum examination showed a polythene ring vaginal pessary, which was displaced vertically in the anteroposterior axis. The posterior semicircle of the pessary, it was embedded in the posterior vaginal wall with a 2 centimeter band of vaginal epithelium over the pessary. This is the picture of the pessary, which was embedded in the posterior vaginal wall with a 2 centimeter band of vaginal epithelium. The second case report was she was a 75-year-old female, para 4, live 4, with previous normal vaginal deliveries. Her last childbirth was 35 years back, and she attained menopause 20 years back. And she was a known case of prolapse for 10 years, presenting to our OPD on routine 3-monthly pessary review. And she was a known hypertensive on regular treatment for past 10 years. Her menstrual history was normal, and there was no other significant history. On examination, her general condition was fair. She was not anemic, vitals were stable, systems were within normal limits, her abdomen was soft. Her speculum examination revealed a ring pessary which was embedded in the lateral vaginal wall with 3 centimeter band of vaginal epithelium over the pessary. And this is the picture showing the vaginal pessary which was embedded in the lateral vaginal wall with a 3 centimeter of band over the vaginal epithelium. Rectal examination of both the patients, rectal mucosa was intact. For both the patients, pessaries were removed under IV sedation by cutting the ring pessary with a scalpel. After the removal of the pessary, the vaginal bed was smooth without any erosions or ulcerations. And re-examination of rectum was done, and it was an intact mucosa. Both the patients withstood procedure well. Post-operatively, both the patients were treated with antibiotics, analgesics, and antacids. Follow-up of the patients after 6 weeks showed not only healthy vagina and cervix, but there was no further descent of the cervix. Incarcerated vaginal pessary, it is the one which is displaced from its original position and becomes embedded in the vaginal or cervical mucosa. If left in situ for years, it may erode into the rectum or the bladder, causing rectovaginal or vesicovaginal fistula. The complication of pessaries are, it may result in foul-smelling vaginal discharge, infections, erosions and ulcerations of the vagina, bleeding PV, itching and irritation of the vagina, incarceration of the pessary, displacement leading to vesicovaginal fistula and rectovaginal fistulas. It may cause interruption with intercourse and contraceptions and may result in vaginal carcinomas. The follow-up patient should return 1 to 2 weeks after the initial insertion and then at 6 months interval. Patient should be asked about symptoms like foul-smelling, vaginal discharge, bleeding PV, and pain and discomfort. And she should be enquired about symptoms of voiding difficulties. Symptoms of UTI should also be elicited. We should look for proper positioning and lack of undue tension of the vaginal wall. The pessary is then removed. If there is any improper positioning or any ulceration over the wall, the pessary is then removed, and the vaginal and the cervical surfaces are carefully inspected for any other evidence of erosion and ulceration. If there is any suspicion lesions, it should be biopsied. If the patient is satisfied with the pessary, and if the inspection is negative, it can be reinserted. If a new erosion or ulceration is present, but which was not present earlier, it may be due to the pressure effect. In such cases, withholding the pessary for 2 to 3 weeks and a local estrogen cream can be used. Once the vaginal and cervical surfaces become normal, the pessary can be reinserted. Of a different size of pessary can also be tried. The conclusion of my talk is proper sized and non-irritant pliable material like polythene and silicone can be used, and proper instructions to the patient should be given regarding a follow-up, making the long-term use of a pessary as a safe alternative for surgery in selected patients. A review of literature. This is a study showing a management of incarcerated vaginal pessaries. A careful instruction for the patients and relatives about the follow-up care can prevent such complications. And the second study shows application of estrogen cream promotes the removal of incarcerated pessaries and does not cause any erosions and other infections. And this is another case showing a thick band of granulation tissue causing entrapment of pessary. These are my references. Thank you.